up, I recognize what our hospital workers are doing to save lives and to be diligent, and we're grateful for them. I'm also grateful today for the work that's being done on our vaccines. And I want everyone to know that while the pharmaceutical companies, the FDA, will be reviewing the vaccine protocols and making a decision on that. In the meantime, we're working hard in Arkansas in terms of being ready for the vaccine distribution whenever it gets here. We're grateful to have Dr. Jose Romero, chairman of one of the key committees that he's meeting today with in terms of vaccine approval process. But in the end, we will make decisions here in Arkansas on a limited supply of the vaccine and how we prioritize that. And it's important for everyone to understand that when those vaccines come to Arkansas, that there will not be enough to cover even the top priority of category, which is the healthcare workers and those in the nursing home setting. And so it's going to be some time, we don't know that time frame, but it'll be some time before we actually get the vaccine that's available for the general public. It is important that we build confidence in this, and the FDA needs to build confidence as they go through this review process. I have talked to the HHS in Washington, Secretary Azar, the FDA, going through the processes, as well as with those that are getting ready for the distribution. And even though they're waiting for the authorization, we know that it's being pre-positioned so that once it is approved, we should have it in Arkansas within 24 hours. And so we're working to be ready for that. And then finally, I want to express my thanks to the Winter COVID-19 Task Force that has really concentrated its efforts on the hospitalizations and how we can manage the hospitalizations as a result of COVID in a more efficient manner and to maximize our space in the hospitals and be ready for the unknown future. And so the COVID task force is really focusing on that from a resource standpoint, and I appreciate their work. One of the things that they recommended very early on, they identified the challenge of non-COVID patients moving out of the hospitals that frees up space for everyone else. There had been a delay in the approval process, and so whether it's from an insurance company or from Medicare Advantage programs, I've issued a letter to you today that I've signed, that I've sent to Secretary Azar, asking for them to expedite the waivers with the private carriers for Medicare Advantage so that we can move people out of the hospital when they're okayed by their doctor to move out of the hospital setting, to have that approval in a quicker fashion and not have to wait sometimes 2 or 3 days for that approval. We are working hard on that aspect of it. And before I have Troy Wells come, I want to show the first slide that really illustrates the need for coordination. These are the percent of occupied ICU beds in Arkansas that are used by COVID patients. Of course, ICU beds are regularly filled up with non-COVID patients as well as the new need for COVID patients. This is by hospital region. As you can see statewide, 37% of our ICU beds are used by COVID-19 patients. But if you look at the Southwest hospital region, 57% are occupied by COVID patients, and it varies by region. And so you can see just in this one illustration how necessary it is to coordinate the placement of someone in a hospital that they have adequate space for it. And so that sets the stage. I want to ask Troy Wells, who's led the committee that looked at these hospital resources, to comment on one of the ideas that was presented.
Thank you, Governor. Good afternoon, everyone. As I've said before, one of our most precious resources from a healthcare perspective is our ICU staff and our ICU beds. So we have worked really hard at trying to identify some solutions as to how we can make sure our Kansans don't go without care that they need. when they need it, and to do that at a statewide level. Let me just briefly explain to you the challenge that we're trying to deal with. On a given day, a patient may show up in an emergency department somewhere in our state, and the hospital that receives that patient can't provide the care that that patient needs. And so they have to begin this process of finding a location, finding a hospital that can provide the level of care that that specific patient needs. And that usually involves a lot of phone calls. You call one facility, they don't have room, you call another one, and it's really a guessing game as to who may have the ability to care for a particular patient. So let me stop there and then talk about a resource that we have in this state that's used for another purpose. We have something that's called TraumaCom, and that was established with the trauma system several years ago in Arkansas. And you can think about it like demand matching. You have rules about certain types of trauma that's received in a hospital around the state, and it matches up with rules about which hospitals can care for those trauma patients across the state. And there's a facilitation process in between two hospitals that helps decide and facilitate that transfer to the appropriate place. So we started to explore how this system could be adapted and used for COVID-19 patients and transfers. So let me just explain basically how this works. A transferring facility, that would be an ED perhaps somewhere in the state, determines the status of a COVID-19 patient and what that patient needs. We would have to use a common, we call it a patient stratification tool. It's a common way of classifying these COVID-19 patients. And all the hospitals as well would be categorized based on the capabilities and resources that they have available to take care of patients. So you think about some of the higher level ICU facilities around the state and others that may not have ICU capacity at all. We have 4 different levels or categories of hospitals. We would then update the availability of those beds and resources periodically during the day and really provide a view from a hospital's perspective on where that capacity exists on an hour-to-hour, day-to-day basis so that they would know which facilities are most likely able to care for those patients. Then this TraumaCom system, if you will, would then help facilitate COVID-19 patients to the most appropriate location, just like we do with trauma patients today. So a patient today may be able to be cared for in a facility that's not in one of the metropolitan areas, for example. And instead of just going immediately to Little Rock or Northwest Arkansas or Jonesboro for care, there may be another community that could accommodate that patient. So we're really trying to match up patient needs with facility resources in real time and provide a way to facilitate those transfers throughout the state. Now let me just briefly talk about some of the benefits. It obviously cuts down on time and the number of phone calls required to move a patient to the right place. It better identifies in a standardized way what a particular patient may need, and then helps to prevent certain hospitals from being overwhelmed with patients from around the state that might be able to be cared for elsewhere. So we're really trying to maximize the use of those scarce resources, ICU beds in particular, and look at the whole state and take care of all of our patients in Arkansas. So I want to thank the subcommittee members for helping to work on this, particularly Dr. Jones that's here with us today, has really done all the legwork, and this is a recommendation from the subcommittee to Governor Hutchinson. Thank you.
Thank you, Troy, and I join in thanking Dr. Jones, who will have the lead responsibility in implementing this change to our TraumaCom system. And she's looked at it from a cost standpoint, as well as Stephanie Williams, the Chief of Staff of the Department of Health. And it's estimated that this will add about $70,000 in cost every month because we're going to have to hire personnel. It takes some expertise. We estimate that it'll take 2 weeks to get this system in place if we find the right personnel quickly for that. Dr. Jones will have the lead in getting this done, and we look forward to being able to utilize this tool for the benefit of our hospitals and the management of the COVID-19 patients. So Troy, thank you for the excellent presentation and the recommendation. We accept that recommendation. We'll work to get that implemented. Now let's go to the case statistics for today. If you'll go there, we're going to go through this fairly quickly, but I wanted to report that in the last 24 hours, we've had an additional 1,950 cases. Obviously, this is higher than yesterday. It is less than it was a week ago, the same time, but with the holidays, everything is a little bit out of kilter, and so we can't read too much into the fact that it is less than it was 1 week ago. If you look at our confirmed deaths, the total additional deaths are 10 over the last 24 hours, which is a sad note after the Thanksgiving holidays. We have 11 additional hospitalized, which is down, but it's still an increase. That gives us a total of 1,074 that's been hospitalized, 6 fewer on ventilators, and you can see the top counties there, which is fairly consistent with what we've seen in our top counties before. If you look at our testing, we had very high antigen testing that came back into play on Monday. And so we had 4,365 antigen tests, which is one of the reasons we had higher numbers. Our PCR test is 5,161, which is lower than what we like to see it. And I think in the coming days, you're going to see more PCR tests coming in, which probably indicates that there'll be an increase in some of the numbers that we see in our positive cases. With that, let's look at it from a different fashion, which is the graphs. And the first one, you can see it from a comparative standpoint. The orange, of course, is our new confirmed cases, the probable cases on the antigens in the white, and you can see the balance that's there. And again, higher than yesterday, a little bit less than a week ago. The next one, you can see the trend line, and again, even though it's pointed in the right direction, I'm going to discount that because of the holiday skewing things, and so we'll wait and see how that develops. Next is, again, this is week-by-week comparison, and if you actually look at the last week, we had fewer than we had 2 weeks ago and fewer than last week. That's good news, but here again, I think I'm not going to put a whole lot of emphasis on it because of the holiday season, and I think the next 2 weeks are going to be more telling than even the last week. This is the currently numbered hospitalized, 1,074. We've mentioned that, which is a new all-time high. This breaks it down by region in terms of the 7-day rolling average of new confirmed and probable cases in Arkansas. And I do like whenever I see those trend lines going down from the Northwest down to really each of them. But let's wait and see as we get more information in the coming days when our PCR tests get back up to normal and we get some of the results from our Thanksgiving weekend. That will be our grade, and we'll see how we do. This is the growth rate by region. I just like to show once a week that Central Arkansas and Southeast Arkansas is growing at 7.5% in cases. Northwest dropped down to 6.6% in new cases from November 22 through November 28. Next, we'll see the 7-day rolling average of percent positive cases in Arkansas, and these are PCR tests. And this is more significant that you see, what is it, man, it's about 10 days ago that we reached this peak of about 11% in PCR test positivity that has dropped. I think that is a real drop in that positivity rate, even though the last few days might increase a little bit, but we're teetering on the 10%. Hopefully we can stay below that. The next one this is, the last day of the month for November, and so let's look at how we did in our testing. 333,000 PCR tests during the month of November. 333,000 is over 10% of the entire population of Arkansas tested in 1 month. And I recognize there could be some duplicates, that somebody might be tested twice, but we're actually going to try to narrow that down. But you have a margin of 33,000, you still are testing 10% of our population in 1 month. The next one, you'll see the antigen test that we're so far exceeding the goals. People are utilizing it. It appears to be continued improvements in its accuracy, so it's much more reliable. 59,000 antigen tests in the month of November. And here is the cumulative total of percent positive PCR tests. That's August to the present which is very similar to what I showed a moment ago. So let's go to the next one. And I think that concludes that. So with that, let me shift to education. And it appears to me from the national commentary that there is a growing national recognition that our schools are important to stay open. And you see New York City, they've been as tight and restrictive as any state, and yet they've opened up the schools in New York City again. You hear Dr. Fauci articulating the importance of schools, and so I'm pleased that we're the hard work of our teachers in making sure our schools can stay open, and sure we have to switch to virtual from time to time, but schools staying open is increasingly important for the education and well-being of our students. And so the teachers are critical to this effort. We've had to rely upon substitute teachers. We've had to rely upon additional staff. Sometimes schools have had to close because of a shortage of staff and teachers. And so just as we did with the nurses, I'm pleased to say that the State Department of Education will be asking the Board of Education to waive the application fee of $75 and to expedite the applications of a new round of teachers that will be coming out of school this next semester, and hopefully we'll be able to get them into the classroom and available for our schools in a much quicker fashion and also with some assistance and incentive by waiving that application fee of $75. This is similar to what we did with the nurses. Someone raised a question, well, many of the nurses that we had covered had already applied for their application and paid their fee. I want to say that we will be refunding that application fee for those 800 nurses that had already paid that. So that will be fulfilling that commitment and expediting those nurses to get out there, but it's important to have the teachers available as well. With that, I'd like to have Dr. Ivy Pfeffer to explain that more fully.
Thank you, Governor. We do have 29 active modifications right now in our schools. So we have had 29 different instances where schools have had to modify some type of whether grade level buildings or their district to remote learning. That is down from previous weeks. 10 of those started this week, but every time we look at these modifications, more often than not, it is staffing issues due to quarantines that are the main driver when districts have to pivot to remote learning. Because of that, as the governor stated, we are going to be seeking approval from the State Board of Education to waive the $75 license application fee. This will be for first-time licensees in Arkansas. These licenses would be issued to those who are completing a program of studies, so oftentimes new teachers. It could also be a teacher coming into the state through reciprocity. The teachers will still have to have their background checks. They will still have to complete the Central Registry Child Maltreatment, so those things will stay in place. But this will allow us to be able to expedite the paperwork for these teachers to go ahead, get their licenses. In some cases, there may be vacancies that they can fill at the semester. In other cases, they may take on the role of substitute teachers. But when we look at the similar period over last year, so we'll ask the waiver to be from December 1st through April 1st of next year. If you look at that same time period last year, we had about 500 new licensees at that time. So this really is a significant opportunity for us to be able to more quickly get new teachers able to be in the classroom, able to be employed, and able to provide a little bit of relief to our schools who may need that additional personnel. We also, for information, we've got the contact information there for our Office of Educator Licensure. New teachers will be referred for licensure from their Ed Prep program. reciprocity candidates can contact us for the paperwork, and that way we can be sure to follow through on expediting all the necessary information. We also want to just take a minute to give you our first update from our Engage Arkansas campaign. If you remember, a couple of months ago, we began this strategy in partnership with our Education Renewal Zones and with Graduation Alliance. And the strategy is really focused on two things. Number one, being able to find students who maybe did not return to school this fall, but also helping us to engage or re-engage students who, because they're at home learning remotely, may not be as engaged as they had been in the past. So we currently have 110 districts who have opted in to Engage Arkansas, and currently student outreach and support is underway for almost 5,000 students in efforts to re-engage them in their district's current instruction and learning environment. 74% of the students have agreed to receive academic coaching, and that is taking place. And the early data is showing that families really do have a willingness to partner, to take advantage of any opportunity to get their students some extra support. Most are reporting that their students are struggling, especially in reading and math. And so what we want to do is continue to work with Graduation Alliance to really unpack all of the details around that, to then supply the information back to the school so that they can understand what's going on with their students who are learning remotely. So all of these things work together in support of students, trying to keep everyone at school for the maximum amount of time as safe as possible. Thank you.
Thank you, Dr. Pfeffer. And with that, we'll turn it over to questions, and have Dr. Dillahay here and Dr. Jones and Troy, and I'll defer questions to them as needed. But with that, we'll start with the questions.
You mentioned the supply of the vaccine is not going to be enough to cover the high priority group entirely, at least initially. How is it going to be prioritized within that group?
We're still working on that, and we're actually going to give another assignment to our Winter COVID Task Force. We got some really key people in the healthcare industry there, and we want to get their insights on this as well. I had a conversation with Dr. Romero about this today, and while right now maybe our allocation is 25,000 vaccines, well, and just we might have over 60,000 hospital and healthcare workers, and so you can see some decisions have to be made. Now that number of 25,000, I expect that very well could change in the coming weeks. They're still trying to figure some of this out. The first one's going to be the Pfizer. There's going to be some that's going to prefer Moderna if that's approved because it's easier to store. So some of that is going to be information that we still have to gather before we can make those final decisions. Those are state decisions as to how the vaccines are allocated within our state. We want to wait and get the guidance from our CDC advisory committee, and then we'll make decisions from there.
It's kind of alarming to see the numbers of the percentages, at least in there in southwest Arkansas. I guess what's the difference in the hospitalization just set up in that region than maybe some of the other regions in the state?
Dr. Jones, you want to take that on?
So there is a difference in the raw numbers of hospital or ICU beds in the different regions. Obviously, our bigger metropolitan areas have bigger hospitals, and thus they have bigger ICUs with more beds, and so the percentage would be smaller there. Another thing that I like to mention is that ICUs are not all created equal, and what is put into an ICU, say in a smaller rural hospital, might be something that's applicable to be managed on the floor in some of our larger hospitals. And so that number is probably due in large part because of the raw numbers, but it can also be due to the type of patient that's being put there.
So I guess what kind of additional strain does that sort of put on more rural areas of the state?
So obviously, if they're putting things that can be taken care of on the floor in other places in their ICU, that could comment or be a marker of perhaps the comfort level of physicians that are taking care of patients in the hospital. And so that would be something we would definitely look at in terms of needing to decompress, or how we would factor that in terms of whether or not patients need to be moved. But I want to emphasize that the primary responsibility is, or our goal is, for the patient that presents to Hospital A, wherever Hospital A is, that they are taken care of at that facility. So if it is humanly possible for them to take care of that patient, that's what we want to do. That's going to save resources. That's going to save a lot of things.
I guess in terms of resources, staffing, how does that kind of stretch the staff a little thinner, especially down there in that southwest region?
So, the hospitals that are down there and their CEOs and their leadership are looking at that very carefully, and obviously they're already making ratio adjustments or things like that they need to do in order to try to kind of preserve the sanity of their staff, if for nothing else, but to make sure patients are still cared for in a safe manner. So a lot of that decision-making is made at local hospital level, because they are going to have the best knowledge of what their providers can do.
Troy, do you have anything else to add to that? Any other questions?
About the trauma system, I was wondering, since it seems like patients their condition can change rapidly with coronavirus, is there any danger that somebody could be in a kind of lower level facility and then all of a sudden need higher level of care?
Well, the important part of that is the evaluation by TraumaCon whenever they make the initial assignment. And that's why you need to have the right level of expertise for it. But should you add anything to that, Dr.?
So unlike trauma that has multiple years of experience in terms of knowing what different injury patterns required, what level of care of hospitals, this is something that we're still kind of working out with COVID. Obviously, this has been around for less than a year in terms of dealing with the fallout of the disease. And so what we've done is that there are different scoring models, clinical scoring models, that we would put into a protocol to use to kind of try and predict what type of care the patient would need. Again, that is why the clinical piece of being able to consult with an expert goes into how these patients are moved with trauma, as opposed to with TraumaCom now. What happens, because we have all of those years of experience and all of those that knowledge and research on different injury patterns, TraumaCom and the medics that answer the phone there can essentially determine what level hospital is needed based on injury patterns, based on what the American College of Surgeons has said, for the Committee on Trauma. All of these things have kind of been put in place for trauma. Because we don't have that with COVID, that is where the clinical piece comes in and that consultation comes in, and we discuss with the sending provider kind of different clinical markers such as respiratory rate, what are the SATs, and things like that. And there are a few scoring systems that are been put out there and been internally validated. Again, the data, it's still evolving, I will say that, but recently published in the Annals of Emergency Medicine, one that basically looks at that and looks at different clinical markers as a predictor tool as to who would decompensate in 24 hours. Again, that is something like emergency physicians look at for that initial triage. It doesn't speak to what happens on the floor, and obviously you're not going to be able to predict all of that, I guess is what I'm trying to say. So we're doing the best we can with the clinical markers and the things that have been put out there, and that's what we'll use in terms of making those decisions, those initial transfer decisions. For me?
Go ahead and say your job.
Oh, okay.
You are the ambulance personnel and whoever transfers these patients via the TraumaCom. Do they have enough of the higher level PPE that they will need to transfer known COVID patients?
Yes, I have not heard that there has been a problem with PPE, necessary PPE in terms of N95s and things like that for our EMS personnel. That has not been brought to my awareness, so my understanding is that they do. They have now, since COVID began, we ensured that they had those kinds of things.
Let's go remotely here. Is there any questions?
Yeah, Governor, this is Andrew with AP. Had a couple questions for you. At the outset, you talked about kind of the report card you're going to be watching for to see how things went over Thanksgiving. I wanted to see if you could kind of elaborate on how are you measuring the effectiveness of the restrictions you have in place, including the earlier closing time for bars and restaurants, and whether additional steps would need to be taken, if there kind of what are the factors you're going to be looking at to determine if there need to be other steps. And later on down the road, also was wondering, do you envision the state's restrictions being lifted once the vaccine is widely available to the general public? Kind of is that the marker for that?
Well, first of all, I'd love to have the restrictions lifted as soon as possible. I recognize that they're burdensome. I recognize that people don't like to have a mask mandate that's in place. And so we want to lift these just as soon as we can. You ask on the first part of the question as to what triggers additional action in the future. Well, I've asked the COVID-19 Winter Task Force to answer that question as well, and it's a hard one in terms of what triggers the need for additional hospital space, or what triggers, at what level are we pushed where we have to do more in terms of restrictions or other actions. And so that's something that's a continued evaluation point. From my standpoint, hospitalizations and our capacity to manage the health care of our citizens, both in terms of routine illnesses and COVID, is a critical factor. And that's one of the things that we'll continue to look at. As governor, I always wish I had better data. I wish I knew exactly the source of every positive case, so I could say, here it is, there's a problem, we can address it there. But the data is not that good. Much of it is human data. We have some good information as to where they've been in the last 48 hours, but it's not always clear as to where that case came from. And so those are hard judgments to make, and that's why I've always said, let's don't put economic restrictions on people and restrict their ability to make a living unless we have good data and understand the consequences of it. Next question.
Governor, this is David Ramsey with the Arkansas Nonprofit News Network. You've spoken about how adept hospitals are at making adjustments in terms of ICU capacity, but specifically in terms of staff resources. Are we reaching a hard limit just in terms of having the critical care staff necessary to treat everyone in the ICU? And in response to those challenges, and I think Dr. Jones began to speak to this, are hospitals in the state beginning to change staffing ratios? How widespread is that? For example, an ICU nurse seeing 3 patients instead of 2. Is that something that we're going to see more of? And I guess, is that a concern in terms of what that means for outcomes?
Yeah. It's a very good question, David. I've asked Troy Wells if he would take that on.
I'm not aware of anywhere in the state where there have been modifications to staffing ratios. With or without COVID, there are always days where somebody doesn't show up to work or you're short-staffed and ratios get thrown off a little bit. And so that does, there's going to be a day when that happens, and there are places where that happens from time to time. But as far as making a formal and permanent adjustment to staffing ratios, I've not heard of that happening. I think to answer the other part of the question, in terms of flexibility and what hospitals are doing. You know, I mentioned here a week or so ago that we were expanding our ICU capacity in January. We had to begin planning for staffing back when we began construction. So back in the summer, we started lining up more contract help to come in at that January timeframe when we knew we were going to need to expand and open more beds. So I'm hopeful that as people have started to look at their surge plans and their expansion plans, that they're making a staffing plan for that as well. And it may well mean that a nurse who's used to working in this area has to be retrained to work in this area, and we stop doing less of this so that we can accommodate more of that. So we have to have a lot of flexibility, and we've got to work hard at training and identifying people that can be flexible.
And just to be clear, is that something you see in the coming weeks in terms of a change to staffing ratios starting to happen at hospitals?
Well, we obviously don't want to ever do that. But there may be times in the future where that's necessary to care for patients, and so it's important that we support our nurses. And remember, there's other things we can do too than just add more nurses. We can bring in people to help a nurse expand her ability to care for more patients. So we've got a lot of different ways that we can help expand care and take care of more patients.
Next question.
Governor, this is Alex with Channel 7. Seeing that we've known that hospital capacity could be an issue since last spring, why are we just now getting this trauma system put in place? And my second question is, how do you plan on reimbursing the nursing licensure fees?
How do we reimburse the nursing licensing fee, Alex?
Yeah, how are you planning on reimbursing that?
Well, those who have paid the fee will be refunded the amount that they paid. And so the nursing board will know who's paid the fee. And of course, it's a time frame. It's for this window of applicants, and they will be refunded it. So it's a process that they'll be working on. If you want additional information, we can get our nursing board to speak to you on it, as well as Stephanie here. Did you have anything else to add, Stephanie? No, sir. All right. And then the first part of the question was, why didn't we start the TraumaCon issue sooner? The answer is, I didn't have my winter COVID task force that made that recommendation, and probably the answer is that they were managing it without that necessity very well. And what we saw were regional partnerships. And so within the regions, they were managing it, and that was sufficient. But as we continued to get more cases and more hospitalizations, we recognized the need for a statewide management system. So it's part of the knowledge base that you gain whenever you go through a pandemic and the experience that you have with our hospitals.
Hey, Governor, this is Josh White with KEIT. You had mentioned that New York was reopening schools, and I wanted to make sure that we pointed out that that middle school and high school students are not going back. Is that something that you will look at here, or that we should look out here? I know that the Dem Gazette showed that 400 less public schools cases dropped last week because of the Thanksgiving break. So it's almost as if we've seen this somewhat work. Any idea to look to do that over the next 3 weeks before we hit Christmas break?
First of all, thanks for pointing out that distinction. You're right. And so I made note of your comment there in terms of New York schools. In terms of how it's working in Arkansas, I'm glad that we have the option of going virtual if the cases or the staffing is not sufficient. And so that system has worked well in terms of flexibility. I'm glad that they're able to go back into in-classroom instruction whenever the circumstances allow it. And by and large, the vast majority continue to have that ability for in-classroom instruction. So hopefully we can stick with that. I think the most important thing is what is best for the children. And that is what there is a growing recognition nationally and here in the state of Arkansas as to the consequences for children, the adverse consequences for children when they don't have access to the classroom instruction. and and so we recognize the importance of it, grateful for the teachers and what they're doing, and much of the recognition comes from the experience of the teachers. But we all will continue to have that virtual option as needed. Dr. Pfeffer, did you have anything to add to that?
Just a couple of things to add. When we look at the importance of in-person learning, there are some cases where states are prioritizing younger students with disabilities to be on site, and in some ways it's a little bit easier for older students to manage a virtual schedule. However, anytime students are remote learners for long periods of time, there are some great challenges that exist, and over the next few weeks we'll go deeper into the Engage Arkansas data, but some of the things I think that we really need to focus on and point out is right now our 12th grade students are the most at risk, according to this data, for dropping out and for not re-engaging, and that's concerning to all of us. These students have obligations outside of high school. They also are taking care of their siblings and younger children in the household oftentimes. So when we close off the option for them to be in-person learning, we are putting them at greater risks. We also need to acknowledge the fact that we still have districts that do not have sufficient technology for every student to be a remote learner. I got a message from a superintendent the other day in a very small school district still waiting on 280 Chromebooks. And I think they're in a school with, just less than 500 students. So when you think about those statistics and you think about how that would eliminate learning options for those students, we need to do what we can do in order to keep students engaged in learning and at school to the extent possible, and provide parents with options if students do need to be at home.
Next question.
Governor, hi, it's Neil Gladner at KZNG in Hot Springs. Just a clarification on the vaccines, please. And I recognize it may be a moving target, but you mentioned the 25,000 initial doses. Is that the two-dose regimen mean that's enough to care for 12,500 healthcare or other top priority workers? And then the follow-up is, have you had an indication of when the next shipment will be?
No, that's still preliminary. In part of it, it depends upon what's the production like between now and the time you get the emergency use authorization. So I think the final amount of our allocation is still yet to be determined. It is to be noted that our allocation early on was higher, and it's actually been reduced some, but I'm hopeful that it will come back up. And we got to remember that you're going to have two different types of vaccines at least, presuming that they do get the FDA approval. Dr. Delahaye, did you have anything to add to that?
So it's important to know that the hypothetical 25,000 doses that we get, we can all use. We don't have to set any aside for the second dose regimen. Those doses are being set aside at the federal level and will be shipped at the appropriate interval. So any doses that we receive, we will want to be used right away to get as many people vaccinated as soon as possible.
Thank you, Dr. Delahaye. Next question.
Hi, Governor. This is Susanna with Ozarks at Large on KUAF. I have a question regarding an article that was published in Bloomberg last week. It showed a map based on some Census Bureau data and a survey. It showed that 50% of adults living in households are not current on their rent or mortgage in Arkansas, and they will likely face eviction. I'm just wondering if you're having any conversations about that on the state level, and if so, what are those conversations besides the Fresh Start program, which will not be enough to help nearly everybody who needs financial assistance, especially as the CDC moratorium runs out in about 4 weeks?
We are having conversations, and We have put our Fresh Start funds in place. I had the first conversation about how those been allocated, distributed, what's the demand for those, what's the balance that's remaining. And then secondly, we're waiting on the Congress to determine what's the next round of relief. There should be a stimulus package. I hope they can reach agreement on that. And I'm sure that part of that will be looking at the issue of rental assistance. I've always believed that the most important thing is the rental assistance because otherwise the debt doesn't go away and it just puts the renter further and further behind, and it just puts off the inevitable action by the landlord. And so the assistance is the most important thing. That's what we've emphasized in Arkansas, and we'll continue to look at that.
But odds are that unless there's something from Congress, there's really not many options.
Beyond Congress, there's limited state funds that are available for that. We've used up most of our CARES Act funding. There's always a potential that additional general revenue could be put into that, but that's something that would probably have to be addressed down the road in a legislative session.
This is Susan at KRK. We recently ran a story where ADH employees acknowledged that COVID-19 cases, specifically test results, are being missed by the state, and they couldn't give exact numbers, saying it could be hundreds, it could be thousands. Is this something that you're aware of, and is there anything being done to shore up those holes? And then also off of that, the fax machine reporting was brought to question. Is that something that's being looked at the state as well?
Dr. Seema, I'm going to ask him to respond to that. He's with the Department of Health, does a great job on our statistics. And while he's coming, what was the last part of the question?
The part about fax machines being how the majority of COVID test results are logged by the state.
Well, let me answer that first, that I saw some critical story about the Department of Health that they're still using fax machines. The challenge is not within the Department of Health. The challenge is in some of our some of the reports that come in from labs or from other clinicians that fax it in. And so we have to have that capacity. We're responding to what is out there and the way some people still communicate. We would like everyone to go electronic. We certainly push for that, and that would be helpful to us.
Thank you, Governor. Thank you for that question. So let me clarify about the missed cases. Really what is happening is that there is a delay in which we get those reports. Oftentimes from commercial labs, we noted this months ago in July when we had a large number of cases, as well as recently, that sometimes that there are cases that for one reason or another, there is a certain lag between the time that a specimen is collected from the time that it is reported to us. Unfortunately, there is not much that we can do on the department side if it's taking 7 days, 14 days, 20